So a long time ago I learned that the easiest way to do a lecture is to make other people teach, and so that's what we're going to do today. So I did go back and pull a few pictures from Jacoby, but I will be honest with you, Mike and I have an understanding. We call it mutual assured destruction, meaning that he has enough evidence on me to make sure that I go probably to jail, and I also with him have that. So we keep it very tame, just a few old people and old shots that I love a lot. This guy, of course. And that was always fun. And I think this was the one where he might have gotten the rhabdo after that. So, and Elizabeth, of course, is my favorite person in the world. Today, we are going to talk about that. Incredibly simple, very straightforward. And the way I'm going to do this is really simple. We are going to go through a case, and I'm going to ask you guys, because you're all smart and gregarious and awesome, what you would do in these situations. I got to be honest, cellulitis, right? It's so simple that you need very little. We at LIJ, there is a protocol where if you have cellulitis, you promise to get things like, and then we just admit them before anything else, because there isn't a lot, but so it's really nice, easy stuff. So the case today, 50-year-old presents with leg pain, previously healthy, 3 days of pain, noticed redness yesterday, presents with 7x9 patch of red warm skin, normal vitals. Okay? What else do you need to know? Anything? Vic?
Medical problems?
Okay, none. This guy's healthy.
Abscess or suppurative touching.
Okay, so when you look at it and touch it, it doesn't. So that brings me to first thing. I'm going to actually do, so on physical exam, do you get an ultrasound on all of these?
Not on all of them. If I feel fluctuance, I'll sono it.
Okay, anybody different? Do you guys do ultrasound on all of them, or you think you're pretty good at this?
Rarely would I ultrasound it unless I see something or feel something abnormal.
Okay, when I looked at the studies on ultrasound, I don't either. I certainly don't ultrasound everybody. But when I look at the studies on this, the studies seem to say that we suck at deciding who has abscesses and who doesn't. I don't know if I believe the studies, but I also, like you, same idea. Neil, special labs, anything, what do you do with this? Any labs, what do you do?
Maybe just like chemistry, CBC, but I don't
okay.
technically needs it.
On everybody, or on the ones that you gut feeling think are coming to the hospital, or gut feeling think you're going home? Which way do you go?
Yeah, I think they're sicker, then maybe.
Okay, so potentially, if you think they're going home, no labs at all. Okay, so awesome. If you think they're coming in, Tucker, do you get blood cultures?
Not febrile?
Not febrile.
No.
Okay. In this one, there's a difference between what CMS wants, because good God, if you have an infection, it could be sepsis. And if it could be sepsis, good God, you need blood cultures. But cellulitis was one of the first diseases where blood cultures were proven to be completely meaningless. I got a study with 710 blood samples from cellulitis, where 2% of them were positive, and 4% of them were false positives. So it actually screws you up to get blood cultures. But CMS being what they are, and we need to pay the government, fantastic. So far, not too painful, right? Except for having to sit up here. I'm not torturing you more than usual. Okay, so you looked and you tried to decide, do I think this person is coming in or going home? What makes that decision for you, Vic?
Fever, tachycardia, unstable vitals, failure of outpatient management.
Okay, so outpatient antibiotics, if they've already gotten those.
Yes.
What if they're 1 day into outpatient antibiotics? What if they're 2 days into outpatient? How many days of outpatient antibiotics before you call this a failure?
I would say if they're on outpatient antibiotics, and if the patient themselves says that it's spreading, it's getting worse.
Good God, you listen to a patient? That's awesome. Tony would be so proud. Awesome. Anything else?
The-
Are there certain people with pre-existing diseases where you go, shit, I got to be more worried?
Diabetes.
Diabetes. All right. Anything else?
Otherwise immunosuppressed if they're on chemo
HIV.
or steroids.
Awesome. All right. Steroids. Okay, we'll come back to that. Do you get imaging?
If I think they're coming in.
Okay.
Yeah, and if I think there's something.
When you say get imaging, is it the chest x-ray for admission, or you get an x-ray of the...
I guess the big things I'm worried about if there's like some foreign body that unlikely, but
Okay.
should be there, or if they have like neck fash and gas, that would be the thing that I would be concerned about.
Fantastic. Your gut feeling as to how good x-rays are for discovering, neck fash and air.
Not very good.
Right. So it's actually better than I thought. Gives me about 35%. I just thought if it's there, then should I have my answer? If it isn't, then I don't have my answer. But it doesn't rule anything out. So that's perfectly reasonable. What bugs do we need to cover for this? And it's fitting what these guys have said. No pus, redness that looks like that. Probably going home. What bugs are you covering? What do you say?
Strep.
Okay. So that's it, group A strep.
That's it.
God, I love it. All right. So what antibiotic? If we're only covering group A strep, you send that home. What antibiotic are you sending them on?
Keflex and Cia.
Keflex and CU. Everybody would go for Keflex and CU.
If we just worry about
Clinda.
It's like sometimes it's like attending preference. But
Okay.
you do Clinda.
All right. Anybody else? Single agent home.
If it's this uncomplicated, probably.
If it's your own company.
I mean, all depends on your
cellulitis, yeah, covered.
Yeah.
Okay, I love it. That has not been my experience. Although you are saying what I love, because about 92 to 97% of these will be strep. Not always group A. Sometimes they're talking about group G. I don't even know what group G is, right? But it's strep, and it is not very resistant. And to be honest, we still get a 94% cure rate with penicillin. You know, that drug that costs like 8 cents a pop and cures my syphilis and that sort of thing. But is that cheap? But we go with Keflex, that's fine. But my experience is that a lot of people are going, MRSA is everywhere. MRSA is on skin. Cellulitis, we need to cover both. And it has been my experience that a lot of people get sent home on Bactrim and Keflex. I love that all of you don't do that. I think it is perfectly reasonable in the absence of pus. I have to ask one question of Matt. Matt, do you ultrasound all of them?
Cellulitis?
Yeah.
No.
Okay. Okay.
I won't admit to that. Don't tweet that.
Okay. So who gets IV antibiotics and who gets PO antibiotics? If you're sending someone home, PO straight, go home, a dose of IV in the ED, and then home.
Say it.
What's going on, man? So what do you do?
I think for this person, a dose of PO and home would be perfectly reasonable.
So PO and home.
Yeah, I never really understood that rationale, like giving them something. Often it's like a different agent. I mean, I guess if we don't think they're going to get the antibiotics timely, maybe, but it doesn't.
Justify the.
Yeah.
Okay, Meyer, what do you do?
I didn't hear the question. You're giving me that leg.
So you think you're going to send home a cellulitis?
That leg.
That leg?
Diabetic?
No.
So what's the question?
PO or IV and then PO?
No, bullshit IVPO. PO, put a black line on it that never goes away and send it home.
So then once they're cured of the cellulitis, they have this beautiful tattoo memory of their cellulitis. That's outstanding. So
Do a duplex. Everybody, I got to rule out a DVT. Stop that.
good. If the skin hurts in the front, that ain't a DVT. I'm with you. Although it would have been one of the things I harassed these guys, and now I won't.
It's blistering though a little bit.
I believe there's scale.
Okay.
Okay.
So Tom, I would, just to play devil's
Good.
advocate.
Knew you would.
In our patient population where there's inadequate access to pharmacies and all that, I would sometimes consider giving a dose of a longer-acting IV antibiotic, and then, the classic.
You're going to give Ceftriaxone because it should be in the water of anybody walking into the emergency room anyway, right?
Our patient population, if they come to Jacoby and they use the Jacoby pharmacy and it's a Saturday overnight, they can't get to the pharmacy till Monday. I'd rather them have at least some long-term coverage, mostly because the nurses won't dispense pills; they're not supposed to.
Okay, I love all that. It's caring, it's wonderful. Let's all hug. What do you got?
Oh, we're done now for like 15 minutes.
All right, 8 words. Go.
Same lines, finger sticks for everyone.
That was pretty good. Awesome. Love it. 8 words. He's in there. All right. So the IV antibiotic thing treats us nicely, does not treat the patient very much differently. Outcomes are the same straight across the board. A trick which you guys may have been, that I learned at Jacoby because I did not want to put in IVs just to give someone 1 dose of IV antibiotics, and I had attendings who wanted me to, is I found the, look, Elvis, to be able to send people home, and that was Probenecid, right? So do you know about Probenecid? Probenecid, like gout medicine and stuff, so we don't pay attention to it, but it also has the side effect of preventing the excretion of beta-lactam rings. So if you are giving Keflex or a penicillin and you want to make your attending buy into the, well, we care and we want to give the long-acting coverage, so you give Probenecid 500 with the first 2 doses, and it keeps your tissue levels up higher. Does nothing for outcomes. Like, this is a complete show, and that's fine, but it's a nice trick to know, so that you can convince your attending, good God, send this guy home. All right. Observation units. Cellulitis observation unit. I like to expose you guys. I like to expose myself as much as possible. I like to expose you guys to the concept of an observation unit, because there is more in this world these days than admission and discharge. And I suck with observation units because I'd never had one before, but I will say one of the things that happens in observation units is you take a cellulitis on somebody who has diabetes but is otherwise okay. Someone when you're on the border and you give them antibiotics and you watch them for 24 hours. You guys buy into that?
24 hours.
How many days are
48.
like in 24 hours.
Right.
So weirdly, it seems to. I think it's because they have it usually on the lower extremity, and they are actually elevating it for a day and working up to that DVT that they're going to get later.
Or it's just getting better on its own.
So antibiotics really kick in close to 24 hours in. So the 24-hour thing, I have never put anybody into the OBS unit for this, but when I cover the OBS unit, I work hard to send these people home. And it is one of the things that very commonly will get an ER extra money is when you do this. So I just want you to hear those words occasionally so that you know these things exist. Okay.
Are you guys really discharging this patient this late?
Yeah.
You're in discharge?
Yeah. You're not?
Who is this? Area is it's almost circumferential, and there may or may not be a little spot. I mean, if you look at the top of this picture or that picture up there, let's be honest. None of these residents are going to discharge the patient.
I am. I guarantee you he is.
Oh, God. Hey, 100 out of 100.
So I kind of believe that cellulitis deserves outpatient trial. And I would say that's true of honestly most cellulitis. A diabetic whose sugar is off, yeah. But I actually believe in sending a ton of these home because if you admit them, it's 2 days of getting exactly what they would have gotten at home. So what's your logic? Bring it.
You know, the IV antibiotics can be.
See, it's not all you guys. I torture everybody.
You're giving, when you send these patients home without if it's a non-purulent soft tissue skin infection, you're just going to give them Keflex when they go home. Right?
Yeah, absolutely.
And
straight up.
I mean, in the hospital, you're going to give something IV like Ceftriaxone.
So that hasn't been shown to change outcome. IV versus PO. So it's why do we keep changing the lights? Can I have some lights, please?
I fire away from the lights. Someone's wrong with that light.
So I don't disagree. I think you can justify it. I think it's a $10,000 admission that's absolutely justifiable. But I actually think that they're going to do fine. How many have you seen, in percentage-wise, of cellulitis come back and go, "Good God, I need to be admitted"?
A decent amount, right?
Okay, they come back. They're still alive.
What about putting a marker and just saying to them, if you get beyond X point, then come back?
I mean,
Let them observe themselves at home.
I think it's reasonable, but at a certain size, I think that it might not respond to PO as well as IV. This picture being, half the leg and circumferential or whatever, I think might not respond as well to.
I think it's better in patient population. There's some patient populations that they're not going to follow antibiotics. They're going to decide how much they need to take. Compliance is going to be low.
You mean doctors? Because doctors suck at taking all the meds they're supposed to do.
Some patients are the same way. They choose, use it heroin. It depends on the patient population. Some of them are not immunocompromised, but they have other, substance abuse.
Okay, admitting because you don't think someone's going to be able to get the medicine, perfectly reasonable. But let's assume that this is a population, you're going to admit this. Oh, I think that's perfectly reasonable. There's always gray zone. What do you got, Pick?
I have committed every sin that is since I've done all of these things. I took a gram of Ceftriaxone. Now you're covered for a day. You can go to your pills. You can get your pills for 10 hours, 12 hours. I've done the go to the CDU obs unit. We'll try to get you out tomorrow. Right. I've done the forget it, just pills at home. I've done the this is too big to get better soon. Let's just admit them. And basically, you can argue for all of them. When we were putting people in the obs unit, we would say who failed. Who didn't get better in about a day? A lot of them failed, and it was big when it got there. It wasn't much better by day one. The patients felt better, right? The fever was down, the pain was better, but the mind was exactly the same. And
As usual, I'm talking too fucking much. Because we're not even a third of the way through what I wanted to get through. We'll make it work. We'll make it work. I want to give time for the ED games because that stuff's fun.
You can't look at it so short term, right? You can say, oh, it's not done yet in a day. Nobody thought it was going to be done in a day, right? So when you put them on pills and go, I know it looks ugly, and it's going to look ugly for a couple of days, and they go home, they don't all come back. So I think it's just are you comfortable saying, I'm going to get 80-90% of you out to eat the, some of you that are going to come back in 3, 4, 5 days. And the people who don't take their pills, they leave with prescriptions for pills. You don't take your pills, you're going to be back anyway. Right?
Bottom line, everybody's right. Got to move forward. You had something quick to say?
I was just going to add to that 1 in 7, regardless of the antibiotics you choose, are going to come back in treatment failure with possibly an abscess. And then,
Wait, no. I disagree with you completely. Okay. Abscess is a different disease. They're not the same disease process necessarily. If it's group A strep, then they may come back with treatment failure, but it's usually cellulitis if we're talking about cellulitis.
Tom, did you make them come back for one check?
I don't, in normal, healthy people. I figure they can, if it still hurts when you poke it and you want to come back, you're welcome to come back. Just 2 other things I want to do with cellulitis as options for you. Do you give anything else besides antibiotics?
Payment.
Hugs.
You know your audience.
So, just so you are aware, studies have shown that NSAIDs decrease the amount of inflammation, and it will look better in a day if you've given NSAIDs. There was a fantastic study in 1997 that shows pain less, size of it less, healing better with steroids. So 1 dose of steroids with your cellulitis has been looked at positively. I just reviewed another study that's going to come out in Academic Emergency Medicine that says basically the same thing that the 97 study did. There are 2 or 3 studies on kids with periorbital cellulitis who steroids have been shown to be very good in, although they were doing shit like following calcitonin levels and things that I can't pronounce or spell. So I just want you to know that along my continuing quest to make people realize that steroids don't make infections get worse, it is one of the things, unless it's fungal or TB. And cryptococcus. But that's not cellulitis. So I just want you to be aware that steroids, NSAIDs, good.
What steroid do you give?
It actually doesn't matter. There have been both dexamethasone and prednisone used. The prednisone was a 3-day and the dexamethasone was a 1-shot. Tony! What? I don't remember the dose of them. All right. I actually had so many good pictures of Tony and did not include them because I did not know he would be here. All right. I probably pocketed it. All right. So, very quickly, to move on to the second part of this talk, I wanted an interlude to talk about questions, right? So again, we're going to hit you guys up with questions. If you have this incredibly adorable creature and it bites you, what antibiotic do you use? And what bugs do you cover in?
Pastorella multicity.
Okay, so Pastorella, and you use?
But I'm not sure.
So Augmentin seems to be the way to go, right? What if this? Well, actually, let's go with this bites you. What are we worried about in those bites?
Salmonella.
Salmonella, fantastic, right? So what if this bites you?
Nothing.
Rabies.
Okay, but let's talk about the rabies issue at the end, right? Do you guys? So cat bites, almost universally, you give antibiotics, right? And that's actually in the Cochrane and guidelines and all that. Dog bites, a little more questionable, but I've found that most people still want to do Pastorella and still want to give Augmentin. Fantastic. What?
And allergic. They're lying. They're lying.
Yes, that is one option. So what do you like?
I actually know these. That's why I'm asking. I would Google it.
Doxy.
Or Bactrim.
Or Bactrim. So the main thing with Bactrim, if you choose to use it, is Bactrim tends to suck with strep, right? So you've treated the dog bite part of it, but you haven't necessarily treated the strep and staph that's on the skin to begin with. So some people will do the two, like something else that covers skin on top of the dog bite or not, right? What if this guy? What are we worried about here? And what do we give? So valcyclovir or acyclovir for a macaque bite. I just wanted to say the word macaque. I gotta be honest with you. That's the whole purpose of that slide, right? Right? What if this guy bites you? All right, so I'm hearing rabies.
No.
That's a no, right? Rats are not rabid. Rabbits are not. That's a whole other. So realistically, you treat it just like a cat bite. Is what everybody sort of recommends, and you don't have to worry so much about rabies. What if this guy bites you? So what bug are we worried about? Eikenella, and what are we given? Penicillin. Straight penicillin, right? So because you said that, let's go back to cats and dogs. Pastorella and the Capnocytophagia carnivalis, the two ones that are in dog mouths, right? Absolutely covered by straight penicillin. So if you just wanted to cover the Pasteurella or the Eikenella and you didn't worry about the staph and the strep that is in the skin, you could do straight up 8 cents a pill penicillin again. So I like that you're thinking about that, because Augmentin can be up to $130 for the prescription, and not everybody can do that.
Tom, I knew that because of a case I had with you.
Yes! So, what if you get bit by that? I think you got to cover both. Right? So shark bites, Vibrio, and you're supposed to absolutely, even minor shark bites, you are absolutely supposed to cover. And Bactrim works beautifully. Doxy works well too. But I wouldn't necessarily think shark bite, oh my God, I'm supposed to cover it. You really are. And then you'd have to cover with penicillin for the puppy bite. All right. I'm absolutely talking too long. I have a whole thing on neck fash. But I want to do, so I'm just going to bring up the 4 points and not torture you guys nearly as much. So what's the whole thing with neck fash, right? The whole thing is the only way to treat neck fash is to go to the OR. And I hear Mike say this all the time. So your job as an ER doc is to try to convince others that this is in fact neck fash. My favorite neck fash case of all time was a woman who came in to Jacoby. We got a pre-notification from JFK that she was coming in and she'd been bitten by a snake on a plane. I am not kidding you. We actually got that notification, right? So 40 minutes go by before she comes to us, and the whole hospital hears about the woman who's been bitten by the motherfucking snakes on the motherfucking plane, right? So by the time she gets there, everybody has this in their head, and she comes in and she is a 20-year-old in like a bathing suit who is septic to beat the band. She looks terrible. She is out of it and all that, and she has these 2 little puncture wounds on her inner thigh. And the first 10 minutes of the case are people walking into the room going, mother frickin' snakes in the mother frickin' plane. And then we have to completely switch mindsets to realize that she has the erythema around it, and she is septic, and what can do this? And in the first 10 minutes, we see the redness get bigger. So we realize that it is neck fash growing right in front of us, and it's going to kill this lady. But everybody we call comes back with, well, what about the snake? Have you given antivenin yet? Da-da-da-da. They would not. It was anchoring like you wouldn't believe. Even the attending surgeon, who we had to call down, was like, did you give antivenin? I'm like, there's no freaking snake. It took about an hour and a half longer than it should have to get her to the OR, and she in fact grew out Clostridia and all that. So
you got a film?
I did get a film. She had no air.
She had crepitus?
She did not have crepitus.
How'd you get into the OR?
I got her to the OR by standing in front of the surgeon and saying, this is what's going to kill her. The only way to stop this is going to the OR. If you don't take her to the OR, she is going to die.
They bought into that.
They bought, because first I made the senior really nervous, and by the time the senior called the attending, they had it in their head that it wasn't a snake, but I still had to go through the antivenin thing with the attending.
So snake aside, though,
right.
I'll tell you, because I defended innumerable docs on these cases, that's the only way you're going to survive this case, or this patient survives, is that. Because you can't show the surgeon's data to get them to go to the OR. You got to just convince them that this patient has it clinically. You don't get the air, you don't get the crepitus.
So there is a scoring system, right? So just to back up Meyer here, the X-ray, low sensitivity. CT and MRI, okay sensitivity, But CT you might get a read on, but I guarantee you that the resident who's on at night with you has never seen it before. MRI, really quite reasonable, but if you put them in an MRI for 20 minutes, that's another 6 inches of leg that they're lost, right? I mean, so you can't do that. There are scoring systems. What are the whole reason for scoring systems? You guys know the reasons for scoring. Why do we have the heart score? So that I can send someone home that I want to send home. Why do I have the PERC score? So I can send someone home that I want to send home doing nothing. So there is a scoring system, the laboratory risk indicator for necrotizing fasciitis, which has terrible sensitivity and specificity. But it gives us the ability, if you have a bunch of this stuff, and there's a little bit on hyponatremia, and it's a high white count, and it's a CK, and a low crit, and a bad creatinine, so you'd have to look it up on MedCalc because nobody can remember this shit. And if it were positive, it's easier to convince the surgeons to go because they've never looked at this before. And it's all about having enough ammo, just like you're saying, to get the surgeons to do what's right, because you will kill people by not doing something. Inaction kills them. And so we've had this before, right? We had a case with, there was bullseye on this patient. Usually by the time there's bullseye, people are going, oh shit, that's neck fash. It's too late. They were probably going to die, right? The death rate for neck fash across the board is 46%. It's been as low as 17% at some places and as high as 76% in some places. So by the time there's bullseye, you're closer to that 76% death rate. So there was bullseye on this patient, and the surgeon, the ex-chairman of surgery, came down at Jacobi and dissected into the fascia. And the trick is you're supposed to stick your finger in there, and if your finger dissects everything away from the fascia, then that's neck fash. And it's sort of a sudsy dishwater is the way that they talk about it, fluid that comes out of there. And you do it sort of a little bit above where the redness is, because the neck fash in the lower levels of the skin is supposed to travel ahead of the infection otherwise. And that is surgery's test. Only the one time I saw it done, the person came down, went, it didn't dissect with his finger, and he refused to take the person to the OR, and that person died of neck fash.
Can I make a comment?
Yes.
So I've had patients where they have been evaluated by senior vascular attendings who recommended things that were outrageous for the patient. And they developed hemorrhagic bullae, and they had, you know, extending obvious redness and stuff like that. If you can't convince one surgical team to do it, then you have to try to reconvince them, or you can try another surgical team, or if that doesn't work, then you have to dissect it yourself. But if you think that this patient's dying of neck fash, you can't just be like, well, my consultant said it's not that, and then give up, because these people will die. And this lady had no medical problems. She was like an ambulatory 60-something-year-old patient, and between when she was handed off to me and, you know, whatever, a fourth-year general surgery resident flayed her leg open, and she died 14 hours later in the SICU. So you have to be very proactive about this.
And you can understand the surgeon's point of view with this. You're taking a 20-year-old woman who just left the beach, healthy as can be, in the case of my non-snake bite lady, and you are basically taking off a quarter of her leg to save her life. And they don't want to do that. They don't want to potentially cause horrible morbidity, because if they're wrong, that's a lawsuit too. So it is difficult, but you have to be the advocate for the patient. 2 other points. Yeah.
Can they have normal vital? Can they have normal labs and still have neck fash?
Of course they can.
Okay.
The only scoring system that looked at that was a white count less than 15, and it was, let's see, it was the white count and, oh, I forgot what the other one. There was one scoring system that basically said normal labs gives them a 90% chance of not having it, but if it looks like it or it's early, you need to do it early. So advocate for your patients on this one. I know, I'm shutting up. Yeah. Have fun, man. Other things that we can do, honestly, any sort of necrotizing infection, throw Clinda in there. It helps with the toxin that the strep elucidates. It's only one of the types of necrotizing fash, but throw in Clinda anyway, as well as what other broad spectrum stuff you're doing. IVIG also targets that, but has not been shown to affect outcomes, so IVIG is not important. Hyperbarics has been shown to decrease morbidity, to decrease the number of times they have to go back to the OR for more debridement. The thing is, there is no way you're taking a septic, hypotensive patient and putting him in that chamber. So although it may work, it is not a patient that is stable enough most of the time to go into our hyperbaric chamber. And if it delays going to the OR at all, then you're doing a bad thing. So although these things are in the literature, practically it's OR, OR, OR. And your job is to diagnose it, to think of it, and to get the surgeon to take them to the OR. And that is not an easy job. So thanks, guys. Thank you.